thematic talk session. Again, just like last time, we're going to have, if you were there last time, we're going to have 3 presenters who are president's competitors. And then we have a 4th presenter who will be presenting on a similar theme as we're trying to create these ideas and concepts together, which is how this all came about. Because usually we have thematic poster sessions. And in this particular case, in this format, we went with thematic talks. And just like last time, first of all, I always do this. I always forget to introduce myself. My name is Lex Gidley. I will be moderating. If you have any questions throughout, we're going to do it just like we did last time. Everyone's going to talk. Our 4 presenters are going to give their talk. And then afterwards, I'll be moderating and filtering the questions through me. Please put them in the chat. And I would like you to do 2 things. First of all, I would like you to send them direct message to me so I can find them all. And then second of all, if you could put the first name of the presenter so that I can ask the right question to the right presenter. That would be great. I would really appreciate it. So we'll go 8-minute talks, and then we'll have 10 to 15 minutes of questions afterwards. Our 4 speakers will be in order: Stephanie Cho from Washington State University Pullman, Casey Johnson from Washington State University Spokane Med School. Is that right? Okay. Ariel Cruz from Washington State University Pullman, and then Cameron Munger. I have it still here as a College of Idaho. Is that correct? Okay. So Stephanie, it is your time.
Sounds good. Okay, just to make sure everyone can see that, right? Perfect. So hi, my name is Stephanie Cho, and I'm from Washington State University, which is the home of the Global Triathlon Safety Database and the Exercise Physiology and Performance Lab. I will be presenting an ongoing project in the lab, the Ironman 30 project, and the title of my presentation is Medical Trends for Repeat Ironman Distance Championship Triathlon. So for some background, Ironman distance events are rigorous 3-sport events consisting of swimming, cycling, and running. There are a variety of triathlon distances. However, the Ironman distance triathlon is the lengthiest single-day event, totaling 140.6 miles across the 3 sports. Ironman distance triathlons have commonly led to various adverse medical incidents, such as dehydration, muscle cramps, exhaustion, heat illness, hyponatremia, electrolyte imbalance, hypotension, vomiting, nausea, and many more. Despite these medical occurrences, it is common for athletes to compete in the same event over multiple years, especially in an event as popular as the Ironman World Triathlon Championships. However, to our knowledge, there has not previously been research on medical trends specific to repeat competitors in Ironman distance triathlon, especially not for the same race over a 30-year period. So our purpose was to determine medical trends in nausea, vomiting, dizziness, muscle cramps, diarrhea, and hyponatremia for repeat competitors in a single long-standing Ironman distance event. So really, we wanted to look for relationships between medical occurrences in repeat competitors based on their years of experience at Ironman Hawaii. Like I was mentioning before, many adverse medical incidents occur at Ironman Hawaii. Therefore, there's a huge team of healthcare professionals ready to help athletes at various locations. And every time an athlete receives medical care, this standardized sheet is filled out. And this could be anywhere on the course. So like at the finish line, on the course, at the transition area, but really anywhere in the vicinity of the race. And you can see the standardized medical sheet on the right-hand side, but there's room for demographic information. There's checkboxes with common complaints, diagnoses, treatment, disposition, as well as lots of space to record vital signs such as heart rate, blood pressure, temperature, etc. So here you can see WSU Pullman on the right-hand side, and it's, like I said before, is the home of the Global Triathlon Safety Database. And here is a link to that website if you want to go visit it later. But WSU Pullman is also the home of the WSU EPPL, directed by Dr. Christopher Connolly, like I was talking about before. And this is where data entry and analysis occurs. And actually, the EPPL research assistants put in over 2,200 hours of work into the project, and it took over 1.5 years to complete. So it was a very large project. So here's a flowchart showing how we got to our analytic sample from our total data set. So we started with 10,494 data points from 30 years of data from 1989 to 2019 from Ironman Hawaii. The total amount of visits that consisted of repeat competitor visits. So a repeat competitor refers to anyone that appeared in our data set at least 2 times from 2 separate years of data. So that was 1,621. And out of these 1,621 repeat competitor visits, 607 of these visits were visits from 5+ year repeat competitors. So, so now out of these 607 visits, that consisted of 89 individual 5+ year repeat competitors. And then finally, out of these 89 5+ year repeat competitors, competitors were included for analyses if they were number one, admitted to the medical tent 5 times within a 15-year span. And number two, they were less than 35 years of age at the time of their first visit. So just to go over the statistics very quickly, so bivariate correlations were used to determine associations among medical incidents during the first tent visit. So that refers to just the first year checking into the med tent at Ironman Hawaii, not any subsequent visits. And then secondly, we used a logistic regression analysis to investigate the odds of medical incidents in subsequent years following that initial med tent utilization occurrence. Okay, so moving into the results, this includes that analytic sample of the 51 repeat competitors that I discussed previously, and they were included in this if they experienced any of these medical occurrences during any of the times that they visited the medical tent during any of their years of competition. So really what I wanted to highlight with this graph is how common these medical occurrences are in Ironman distance triathlon. So you can see that the majority of competitors experience vomiting, dizziness, and muscle cramps at some point. So vomiting, dizziness, muscle cramps are all up there. And then you can see that diarrhea and hyponatremia were less common, but still prevalent over the 5+ years, or 5+ year repeat competitors right here. So now moving into this next graph, this includes 5+ year repeat competitors again to the 51, and it shows the occurrence of specific medical incidences based on the year of medical tent utilization at Ironman Hawaii competition. So this does not refer to the same calendar year, just to clarify, it's just years of medical tent utilization at Ironman Hawaii. So you can see that hyponatremia and muscle cramps stayed relatively consistent throughout. So muscle cramps is the green there, and then hyponatremia is the pink at the bottom. But more repeat competitors experience vomiting and nausea as their years of medical tent utilization increase. So vomiting is that purple line that's going up there, and nausea is that red one there. And then dizziness and diarrhea fluctuated somewhat based on years of medical tent utilization, but also remained more or less stable throughout the years. So diarrhea is that yellow line there, and dizziness is the blue. So here, this shows the correlation between medical variables during the repeat competitor's first year of medical tent utilization at Ironman Hawaii. And there are quite a few shown here, but there were two significant findings. The first one, unsurprisingly, was vomiting and nausea. They were correlated with a correlation coefficient of 0.49, and the second was vomiting and diarrhea. So the correlation coefficient there was 0.32, and both of these were significant. But the correlations between nausea, dizziness, nausea, hyponatremia, and nausea and muscle cramps were not significant. And this, once again, just refers to the first visit, not any subsequent visits. So now this one here shows an odds ratio comparing repeat competitors' risk of experiencing a certain medical occurrence in subsequent years of competition after experiencing during their first year of medical tent utilization when compared to a competitor that did not experience the same medical occurrence during the first year of medical tent utilization. So the first thing we're going to focus on is hyponatremia. So you can see there in the red box is 5.71. So for hyponatremia, repeat competitors that experienced hyponatremia during their first year of medical tent utilization at Ironman Hawaii had a 5.7 times higher risk of experiencing hyponatremia in subsequent years of competition when compared to those who did not experience hyponatremia during their first year of medical tent utilization at Ironman Hawaii. So then moving into a similar trend with diarrhea here, repeat competitors that experienced diarrhea during their first year of medical tent utilization had a 3.65 times higher risk of experiencing diarrhea in subsequent years of competition when compared to those who did not experience diarrhea during their first year of medical tent utilization. And then here, this is our last significant result, but dizziness, 0.72. So repeat competitors that experienced dizziness during their first year of medical tent utilization at Ironman Hawaii had a lower risk of experiencing dizziness in subsequent years of competition when comparing them to those who did not experience dizziness during their first year of medical tent utilization. So we also looked at vomiting and muscle cramps, but we didn't find any significant findings there. So in conclusion, initial occurrences of diarrhea and hyponatremia indicate higher likelihood of repeat occurrence in subsequent years. Analyses of additional adverse medical symptoms and diagnoses among repeat competitors and examination of other age groups are needed. But I just want to reiterate here that this is just the beginning of our analyses with this data set, and we will be going much more in depth for the next year. This is actually the beginning of my thesis work, so I'll definitely be continuing this with our data set. And a few acknowledgements. So first, I'd like to acknowledge Dr. Doug Hiller. He's the former Olympic triathlon chief medical officer, one of the 2 physicians inducted into the International Triathlon Union Hall of Fame, and the director of the Global Triathlon Safety Base. I would also like to acknowledge Dr. Christopher Connolly. He is my thesis advisor, my mentor, and the director of the Global Triathlon Safety Database. He's also the director of the EPPL at WSU and oversees the Ironman 30 project. And finally, I would like to acknowledge the EPPL research assistants for all their hard work with the data. So yeah, and I'm definitely open to questions. I know we're asking them at the end, but.
Great. Thank you very much, Stephanie. Everyone can give her a little reaction applause, and we'll move on to Casey.
All right, so I am working on the same database that Stephanie just previously presented on. So my name is Casey Johnson. I'm a second-year medical student at the Elson S. Floyd College of Medicine up here in Spokane, Spokane, WSU. My project is entitled Clinical Presentations of Exercise-Associated Hyponatremia in Male and Female Ironman Distance Triathletes over 3 decades. And again, just to kind of repeat what Stephanie was saying, this is a long-term project working with a database called the Global Triathlon Safety Database. I'd like to give a lot of credit to Dr. Hiller and his group, Dr. Laird, Dr. Miller, and others that were responsible for collecting this data and keeping it safe over the course of 30 years. And then Dr. Conley, Dr. Stephanie, and their group for being the curators of this data and putting the data set together that I was able to work with. So just a quick background on my project, which is focused on exercise-associated hyponatremia. It's defined as a blood sodium of less than 135 milliequivalents per liter during exercise or shortly thereafter. Its prevalence is extremely common in Ironman distance events. It's been reported as high as 20% when testing all athletes for their sodium values. And then there's a lot of life-threatening complications of EAH. This includes encephalopathy, seizures, and respiratory distress. These severe cases of EAH appear particularly common in females. Almost all cases of these severe cases, as well as death, has actually occurred in females. And then there really is a lack of high quality observational studies within the literature comparing risk factors by sex. So that's kind of what the goal of this paper was, to look at how does exercise-associated hyponatremia present differently in males and females. So the study population, as Stephanie previously mentioned, is 10,494 medical records from over 30 years, 1989 to 2019. We had the sodium values specifically for 3,138 athletes. So those are the athletes that we looked at. 885 were female, 2,253 were male. And then the median age was 37 for my specific group, and the range was 18 to 82. So on statistical analysis, we kind of looked at 5 main variable types. These were chief complaints, diagnoses, vitals, lab values, and weight change. We used log linear analysis first to look at the association between 3 variable types, being sex, sodium status, and then those variables, categorical clinical variables that I just spoke of. And then we calculated odds ratios for both male and female athletes, comparing athletes with EAH to those without, and the odds ratio that they presented with a certain clinical presentation. So first we have a histogram of average sodium concentration by sex. And what that y-axis represents is the percent of athletes, male or female, that fell within that sodium range on the x-axis. And what this shows is that females had significantly lower sodium values compared to males. The average female sodium value was 137.4 milliequivalents per liter, whereas males, it was 139.7. Next, we have percent of athletes with EAH who received blood work. And we split this up by male and female, and this is over time. So what this kind of shows is that overall, males were much less likely to have EAH at 21.2% compared to females who on average 29.7% had EAH. And again, that is out of all athletes that received blood work. And then it appears to be decreasing over time with males at 0.3% per year and females at 0.2% per year. And I just want to emphasize that my project was really looking at cumulative data rather than change over time. However, in this group that we are working with, a lot of them are looking at change over time. So there will be more papers on change over time in the future. So the rest of my project is really kind of looking at these percentages and odds ratios. And this is kind of a busy table, so I'm going to try and break it down as much as I can. So this first column is the clinical sign, one of those 5 variable types that we're looking at. So first we have complaints here. The next is percent of athletes with one of those clinical variables. So what this represents is males who were not hyponatremic, i.e. had a sodium value greater than or equal to 135. 5.8% of them had altered mental status, but hyponatremic, 9.0% had altered mental status. Next, we have odds ratios with a 95% confidence interval. And this again is comparing athletes with EAH to athletes without EAH, and males and then females. I want to emphasize that that is separate for males and females, and then a p-value for that. So now I'm just going to go through and identify a few of these that appear to present differently between males and females, and how we determined that is if it was statistically significant in one sex, but not the other. So first we have altered mental status and diarrhea. These both appear to be statistically more common in males with EAH compared to those without. However, this was not true for females. And then vomiting is statistically more likely to occur in females with EAH compared to females without EAH, and this was not true in males. And then abdominal pain was less likely to occur in males with EAH compared to those without, and this is not true in females. Next, we have more of our variables. This is looking at diagnoses, vitals, and lab values. So we have hypotensive, tachycardic, and hyperkalemic. All 3 of these were less likely to occur in males with EAH compared to those without, and this was not true in females. And next, I just wanted to highlight dehydration. This was statistically less likely in both males and females. However, there is one professor, Dr. Hiller, in our group who's actually very interested in this group of athletes who are dehydrated and have hyponatremia, because a lot of the literature is looking at the athletes that aren't dehydrated because that is statistically more likely to happen. So in the future, look forward to seeing that paper by Dr. Hiller. And then we have weight change. So this was very statistically significant. Males were 5.85 times more likely to gain weight when they had EAH compared to those without. And then females, it was 3.32 times more likely. And then a 5-pound weight loss was much less likely in both males and females. And then just kind of a graphical representation of these findings. So this is weight change on the y-axis, and negative weight change is considered weight loss, and positive is weight gain. And then on the x-axis is sodium in milliequivalents per liter. So this kind of identifies 2 main points. And first, it's that males lost significantly more weight than females at 5.8 pounds compared to an average of 1.1 in females. And then then there's a very strong negative correlation between weight change and sodium. And in males, 0.43 pounds were lost per 1 milliequiv per liter increase in sodium, and then 0.37 for females. So just a few conclusions. On average, females had much lower sodium values, and they were much more likely to have EAH when looking at Ironman distance athletes. We found that altered mental status, diarrhea, vomiting, abdominal pain, hypotension, tachycardia, and hyperkalemia all appeared to present differently between the sexes when comparing athletes with EAH to those without. And lastly, females lost much less weight than males did. So what's the importance of this study? First, EAH, as I mentioned, is very common and it has life-threatening complications. So further understanding how it presents differently in males and females helps athletes and medical professionals identify its symptoms early and treat it better. And then next, just the immense size of this data set. It's the largest data set ever collected on this specific population. And then lastly, this is really kind of as far as we can tell, a novel project in comparing many of these clinical presentations and comparing them between the sexes. And then lastly, just one quick note on like a limitation. This study was done over 30 years. So there was a lot of natural diversity in the athletes and medical personnel. And our group right now is working as much as we can to kind of standardize that, as well as do research into the natural change over time and report on that. Sources, and again, I would just like to thank Dr. Conley and Dr. Hiller and all the hours and hours of work that was put into this project before I've been here, and I'm very thankful to be a part of this team. So I will take questions at the end, and thank you everyone for listening.
Great, thank you, Casey. So everyone could give him a virtual applause, and we will now move on to Ariel.
All right, everyone see okay? Good. Yeah, okay. So I will not be presenting on the Ironman project, so a little bit change in pace here. My study was primarily looking at the relationships among occupational characteristics, social isolation, and physical activity among pregnant women. And I am also from Washington State University here in Pullman, Washington. So we know that low levels of physical activity are common during pregnancy. Physical activity is important during pregnancy, and previously researchers have really found that the majority of pregnant women are not meeting physical activity guidelines. Physical activity during pregnancy may decrease risk of gestational diabetes, promote healthy weight gain in the mother, promote a healthier birth weight in the child, and a decreased risk of cesarean birth. We also know that social isolation and feelings of loneliness appear to be common during pregnancy, and this does have a significant adverse impact on physical and emotional well-being. Feelings of loneliness have previously been related to chronic illness, physical inactivity, and an increased risk of all-cause mortality. And then finally, we kind of know in the non-pregnant population that occupational characteristics appear to be related to physical activity and feelings of loneliness, but this has not been examined in the pregnant population at this point to our knowledge. So overall, we wanted to examine how occupational characteristics for this population specifically, that was maternity leave, the hours worked per week, and occupation type, and how those relate to feelings of loneliness, social isolation, and physical activity behavior during pregnancy. Previously, these variables have not been extensively examined within the pregnant population. And as we already know that feelings of loneliness and physical activity are related in the non-pregnant population, we wanted to see if a similar relationship exists within this population. So our participants were recruited from the Yakima Valley, Washington area during 2019. So I do want to note this was pre-COVID and pre-quarantine. So we hadn't looked at any of the effects of social isolation in regard to that. So take back a year or so. And our total participant pool was 295 people between the ages of 18 to 40. Participants were asked to complete a survey related to their demographics, occupational characteristics, so again, maternity leave, their occupation type and the hours worked, UCLA loneliness score, their physical activity behavior, and their social network index. We used bivariate correlations and logistic regression analyses to examine if there was any effect of, if any effect existed between social network index and UCLA loneliness on physical activity behavior, and a one-way ANOVA with Monferroni and Tukey HSD corrections to examine any differences between occupation type. So we categorize that into either work, no work, or homemaker, and their physical activity behavior. So just some quick descriptives. The mean age of our participant pool was 27.6. And our population identified our population identified 58% of Caucasian, 33.8% was identified as Hispanic, and the remaining 8% identified as African American, Asian, or other. As seen above, the majority of our population had at least a high school education or above, and roughly half of our population reported secondary education. With participants that selected other here at the bottom, the most common responses were they were still working on their college degree, they had some college but no graduation, or they participated in trade school. As seen in the pie chart to the right, reported income varied and was fairly diverse. We had decided to collect our data in the Yakima Valley area just so that we could get a more diverse population. Typically, when we recruit participants in Pullman, it's fairly high Caucasian ethnicity and high income levels. So we wanted to try and get a little bit more diverse than what we would have seen here. So this histogram here shows the number of high contact social roles as reported by the participants. For the social network index scoring, an individual can have a score as high as a 12 or as low as a 1. Participants are asked questions regarding their spouse, if they talk to their spouse, their children, parents or in-laws, work relations, or other relationships. And then they are then asked to report if they communicate with this individual regularly, meaning once every 2 weeks. For any of the responses that were answered with once every 2 weeks, you then add those together to get the number of high contact social roles within their life. We also examined the participants' UCLA loneliness score. With this, a higher score indicates a higher level of loneliness. Approximately 91% of our participant pool scored a 46 or below, which has previously been used in the college population as a value representing low loneliness. Again, this is in the college population, not in the pregnant population, so there could be some differences there. And 8.7% of our participant pool scored a 47 or above, indicating a high level of loneliness. The mean score was 32.5, which is consistent with previous findings among the pregnant population. So we further broke down reported occupation into job, no job, homemaker, and then some had no response. The roughly 55% of our participants reported having a job, and we also asked participants to self-report the hours worked per week, and we had a mean of 35.82 and a standard deviation of 10.5. Participants that commonly reported higher work hours, above 60 or 70, were commonly reporting being a homemaker, so they kind of counted that they were 24/7 working all the time. In our population, we found that 38.9% of the population met current MBPA recommendations of 150 minutes per week. This is fairly consistent for self-reported data among the pregnant population, with other studies reporting around 30%, but this is still much higher than in reality, because we all know self-report data, especially for physical activity, is usually higher than actual reported physical activity. We then examined any differences between occupation type, so again, job, no job, homemaker, and if they were in their physical activity behavior, so if they were meeting the current MBPA recommendations or had any physical activity in general. We found no significant differences between occupation type and meeting MBPA recommendations, but found that current vigorous PA was nearing significance with a p-value of 0.79 between the no job group and homemaker group, which showed that being a homemaker rather than having no job may be related to less vigorous physical activity. We then examined how the number of hours worked per week related to meeting the current MBPA recommendations and the UCLA loneliness score. The number of hours worked per week was inversely related to both of these, meaning that the more hours worked, the less physical activity reported, and the more hours worked, the lower the score of the UCLA loneliness. We also examined any differences with maternity leave. While this wasn't significant with physical activity behavior, we did find that being on maternity leave was associated with having a greater number of high contact social roles within one's social network. And finally, we decided to look at the total number of high contact social roles and how they relate to meeting MBPA recommendations, current MBPA participation, and their UCLA loneliness score. The number of high contact social roles was associated with current MBPA participation, meaning MBPA recommendations, and inversely related to feelings of loneliness, meaning that the more social roles one had, the less lonely that they felt. So this is really just our preliminary data. This is a project that I've been working on with Dr. Connolly in the lab, and we are hoping to publish a more in-depth paper this summer. But preliminary data just shows that a relationship may exist between these occupational behaviors, physical activity, feelings of loneliness, and social isolation. We hope to further analyze these variables, and although our ANOVA and regression analyses did not show anything significant, we're hoping to examine these further to see if there's anything there. Overall, pregnancy is filled with many changes. A mother may commonly feel isolated, especially in times like now. The initial relationship between the number of high contact social roles and feelings of loneliness is promising and something that can be examined further. And so far, the strongest predictor of pregnancy physical activity that we have found within our study population and actually previously presented on is individuals' pre-pregnancy behavior, meaning that if the woman is pregnant or is physically active prior to their pregnancy, they are more likely to continue that physical activity during their pregnancy. Future research should really look at the quality of social network in addition to the quantity. The social network index only evaluates the quantity, and someone can still feel lonely, but have a high number of social contact roles. So it's really important to look at the quality and the quantity, and that should be included in any future research. Additionally, it would be beneficial to compare any differences by trimester. For this study, we had just recruited pregnant women as a whole. We didn't have any other requirements by trimester. So it would be really nice to be able to compare how this changes from first to second and then third trimester. And as always, it's preferable to have quantitatively measured physical activity. So perhaps combining quantitative physical activity with the UCLA loneliness score and social network index to further examine those variables. And then if there are any questions, feel free to send them in the chat, and thank you for listening.
Great, nice job. Let's give a nice virtual round of applause there. And we will move on to our last speaker, Cameron.
Okay, I did a resistance training study using eccentric overload. And one piece of information that I wanted to get out of the study was to actually provide a prediction equation of maximal eccentric back squat strength from concentric 1RMs. So the first thing that I'll do here quickly is define eccentric overload. And that is quite simply just applying loads that are greater than concentric maximal strength during the eccentric phase of lifting. So if I were to have a maximal weight that I could lift up on the barbell right here, I could apply additional loads using these hooks. And then as I were to squat down, these hooks would actually touch the ground, unhinge off the barbell, and then allow me to come up with just a concentric load. Now, there are some benefits to this eccentric overload training. An unexpected benefit of the eccentric overload training is actually an increase in concentric strength. An expected one is an increase in eccentric strength. We also see increases in explosive performance as well as early skeletal muscle adaptation. So usually when we have untrained individuals and we get them beginning on a resistance training program, it takes about 8 weeks approximately, the time frame to see skeletal muscle adaptation. But with eccentric overload, we see that in as early as 6 weeks at the single fiber level. And then another problem that we have with resistance training is it's always prescribed off of concentric capabilities. However, depending on whatever specific movement you're using, we could actually produce forces up to 190% during the eccentric muscle action as our concentric. So there's this potential that we might be leaving gains on the table, whether it be concentric strength, eccentric strength, explosiveness, or muscle hypertrophy. So right here is just a simple video of how this eccentric overload is working. As he's coming down, we have additional loads on that barbell, and then he comes up with a lighter load. Now, there are various ways that you could apply eccentric overload. In these top two right here, this is an isokinetic dynamometer, and this is a flywheel resistance training mechanism. This is just a flywheel squat. And there's a problem with this equipment because it actually varies the load, or it varies the force that you produce while you're on the machine. So it makes it hard to make direct comparisons between like constant load training and eccentric overload, because the bottom line that I was trying to get to is, hey, which one's better in what circumstances, whether it be explosiveness, strength, and things like that. So these eccentric hooks right here seem to check most of the boxes as far as like, okay, we can do that in a large dynamic movement. They're very cost effective relative to these other machines. They're time efficient. If you have 3 people that lift a similar weight in a squat rack, then they could work together. However, there's one little drawback to them, and they require a little bit of manual labor. So in my study, every time someone did a squat and they unhinge off of the bars, there was 3 people there to actually hook them back up to the bar for every single repetition of the study. So that is one drawback, but if you're training a team and they're working together, it's not that big of a deal. And then the purpose was just to provide a simple prediction equation for eccentric 1RMs from concentric 1RMs. If we're doing eccentric maxes from this study, we can allow coaches, practitioners, and athletes to forego some of the risk associated with an eccentric max. So the inclusion criteria of our subjects was they had to resistance train the lower body at least twice per week on average. They had to be free of musculoskeletal injury within at least the year prior. And then they had to have good concentric and eccentric technique. So for concentric, they had to be able to squat, whereby the thigh became parallel to the ground and come back up with that with decent form. And then for eccentric, we had to fix a time parameter on that. And what we did was we used the metronome, and we attached a 3-second cadence to that. And they had to descend during the eccentric very evenly down. We couldn't have people dive bombing squats and having gravity do all the work during this eccentric. They had to control this weight at an even pace all the way down. We had a 20% attrition rate. And I know what you're thinking. Yeah, you put more weight on people's back than they could lift up. No wonder. But we actually didn't, none of that attrition was due to any eccentric maxes. We started off with 41 and ended up with 33 that we retained. And 2 of them got injured during our 20-meter sprint sessions. And then the other ones just kind of fell off because they were in a control group, but they knew they were in a leg training study. So that's where some of our difficulty came in, was with the control group. There are their stats right there. So this is the study design. And on our left, we have each of the groups. So EO, eccentric overload, the traditional group that did constant loads, and then a control group. Our control group just did upper body twice per week. Our eccentric overload group, they use these eccentric hooks. Our traditional group used constant load. And you could see that the volume between these two groups for weeks 1, 2, all the way through weeks 5 for the training, they had the same volume. 4 sets of 5 right here, 3 sets of 4, 3 sets of 2. And then if we looked at the intensities, those eccentric hooks allowed us to be able to prescribe an average intensity per rep. So 105% eccentric, 55% concentric gave us an average of 80%. Therefore, the traditional group did 4 sets of 5 at 80%, and so on. We measured kinetics during submaximal back squats, 1RMs, eccentric 1RMs, but we also did vertical jump and 20-meter assessments. But what I'm focusing on right here for this prediction equation is just the post-testing scores, these back squat 1RMs and these eccentric 1RMs. So we were able to find a significant linear regression equation, and participants' eccentric 1RM is equal to 12.22 plus 1.1 times their concentric 1RM when it's measured in kilograms. And we had a wide range of strength in our study because of that minimal strength requirement of 1 times their body weight. So from 79.4 kilos to 190.5 kilos. So pretty good equation considering the wide range of strength from approximately 175 pounds to 420 pounds. So you can imagine 120% on 420 pounds on top of that, pretty heavy squats during the eccentric. So now that you have the eccentric overload equation and you know exactly your eccentric max strength or something close to, right? As much weight as you could put on your back before your GTO say, hey, we're not doing this, and you come crashing down to the safeties on the squat rack. We could use this tool to effectively allow for better prescription of eccentric overload. If we know where our max capabilities are, then we could utilize this information to prescribe those eccentric actions and take advantage of some of that lifting during the eccentric, and perhaps not leave some of this strength, explosiveness, or muscle hypertrophy on the table. So I guess it's time for questions now for everyone.
It is time. It is. So I'm going to start back up with Stephanie. I've had quite a few questions come in. And so we're going to open back up to everybody here. And Stephanie, the first question I have for you is, why do why did you only include athletes at less than 35 years of age, at least at their start, right? Like, I think that's when you started. It was the first visit to the tent was less than 30.
Yeah, so in order to be included in the analyses, the participant had to be under 35 years of age at their first visit. And the reason that we did this was, so this was really a preliminary analysis. And we're going to be diving deeper into the effect of age and the effect of sex and different age groups and all that, probably in my thesis and other publications that we're going to be focusing on the next year. But the reason we decided to do it for this specifically is because we didn't want any really like age-related variables interfering with our findings. So we didn't want, there was quite a few people actually that were 5+ year repeat competitors that were age maybe 50 or 60 and up, that actually had 5 years of data. So they competed when they were 60, 61, 62, maybe like 66, 67. So we just didn't want to include those people in our analyses for this because we thought it would skew our results a little bit.
Great, great. Casey, I'll now turn to you. I have several questions or a few questions about female athletes specifically. Did you record menstruation times? So like, where were they in their cycle when you were collecting this data? Do you know that?
We did not. That would have been a very interesting variable to look at, because in the literature, it definitely says that estrogen kind of has a negative effect on sodium regulation. And that's likely due to, or the reason why we saw that lower average sodium in females. So it definitely would have been very pertinent, but just due to the constraint of kind of this being retrospective, looking back, we weren't able to get that data.
So I have a follow-up question to that. First of all, can you define how EAH was defined for this data set? And then follow that up with, why do you think so many females had a higher incident of EAH?
Yeah, so EAH is defined as, in this study and generally consensus is as a sodium value less than 135 milliequivalents per liter. And that specifically EAH is defined as during or shortly after exercise. So it could be if they came to the medical tent after their performance, we still consider that EAH. Sorry, what was the second question again?
Why do women have higher incidence of EAH?
Yeah, we don't know for sure, but again, we kind of think it is due to that estrogenic effect and its negative impact on sodium regulation. And during these extreme exertional events that is putting a lot of stress on their sodium regulation, it likely is causing that more of them to lose a little bit of that regulation and drop lower in their sodium values.
So one more follow-up question to that was, when were the sodium values measured during the triathlon for your data set?
It was whenever they came into the medical tent, and we used their, some athletes or many athletes received multiple sodium values, but we, to be consistent, chose their initial presentation, their first sodium value taken. But it could have been athletes 10 minutes into the race or after the race, but we used all of their just initial presentation of sodium value.
Great. Ariel, I will move to you. So first of all, I had a comment that thanked you for clarifying that this was pre-COVID. And I would just like to add to that, that I think that this is really, like, the timing of having this kind of foundational information was excellent. So keep building on it. You mentioned that you wanted to look at different trimesters. And the question that came in for you was, how do you think the trimester might affect these results?
Yeah, that was kind of something that I had been trying to ask myself as well. And I personally, the way that I would see it is maybe towards the second trimester, they might be very excited for the baby. They probably are having their baby shower, a lot of overall family support. But then as they move into the third trimester, those feelings might kind of go away because they might get a little scared. They might isolate themselves more because they're in fear of what's coming. Actually, something that I read recently with the COVID pandemic, a lot of mothers are feeling more fearful for their baby, to bring a baby into the world right now than before, when they would just feel excited. So I would expect it now to be a lot different than what it was before, but I think by the third trimester they might be a little worried and kind of isolating themselves perhaps from their family in general, but it would be interesting to see for sure.
Definitely very interesting work. Cameron, I will move to you. Stephanie, don't worry, I got another question for you, so we'll come back to you. Cameron, so the population that you did this on was what age group was again? This was college students, yes?
Yeah, so their ages 18 to 30. We opened it
Okay.
up to women. We had one woman join, and by the time her time with the study was like 3/4 over, I was like, look, you're the only one that's joined. I don't know if you want to do another eccentric max. Maybe we could forego this because statistically we can't do anything with your one data point. So that was
So
unfortunate that they were
yes,
underrepresented.
that's
Yeah.
true. Next time.
Yeah.
So I guess you would say that your obviously your equation is valid for this age group. What do you then see could you potentially project or foresee what it might be for other age groups? Do you think it would be similar? Do you think it would go down? That the equation would change? How do you think it would change for different populations? Or you could think about your own population, because 18 and 30-year-olds are different. So did you see any difference or effective age within your own population?
We did not control anything by age requirement, but we did want somewhere near college age males because they typically have a clean bill of health, and like it is considered an advanced lifting technique. So this could be step one and some other ones. However, a large dynamic movement with 120% plus on your back for like older populations might not be a great idea. So just starting off with this population at first, and at least this movement first. Yeah.
So I have one more question for you, and I'm just going to read this because I will mess it up if I don't just read through it. Although not entirely the same concept, are there any devices or methods for variably loading the concentric portion of the movement such that the heaviest loads are encountered at the weakest part of the lift, i.e. bottom of the squat, and lighter loads are encountered at the strongest part of the lift, squat lockout?
So that's interesting. So like variable resistance, typically thinking of like chains and bands, but they have the opposite effect. It's actually heaviest at the top rather than at the bottom. So usually what people tend to do is they'll tend to just start off or do like pauses within that range of motion. That is their weak point. That's a typical way to go about strength training those weak points. Yeah, but chains and bands, that form of variable resistance has the opposite effect. Yeah.
Great, thank you. That's all I have for you. So Stephanie, we'll come back to you. This question could also apply to Casey, but we'll start with Stephanie here. How are the symptoms related to performance over time? For example, if someone performed better, did they experience more or less symptoms?
So that's something that will actually be addressed in our trends paper. We haven't completely finished it yet, but we plan on publishing it in the upcoming months here. But yeah, that one focuses on 30-year trends in Ironman triathlon, and it'll involve all the symptoms or complaints, diagnoses, treatment, and disposition on that standardized medical sheet. So we don't have the answer to that yet, but we will soon. Casey might be able to answer it specifically for hyponatremia, though. I'm not sure if that's something that he addressed, but yeah.
Yeah, I would say I don't have too much to add besides generally over time, we're seeing hyponatremia decrease a little bit, maybe, and it's not super statistically significant.
How does EAH affect weight loss or weight gain? Because you did see quite a bit of difference in weight gain and weight. I mean, I know that everyone seemed to lose, but there was a difference.
I would say the literature kind of says more so it's the weight change affects sodium more so. And the reason for that is they observe over drinking or over consuming liquids during competition is very correlated with lower sodium values. And the cause of that is because you're over consuming liquids, which is diluting your blood sodium. And oftentimes they see significant weight gains in many of these severe cases of EAH for that reason.
Great. I don't have any other questions. Does anybody? Oh, I got one. This is for Stephanie. What interventions would you use to potentially decrease the occurrence of symptoms that repeat competitors experience after their first year? So if you had someone come in first year, and if you knowing this data, like what would you tell them?
I think so. Obviously, the complaints and things that they experience are all very individual. And I think training for an Ironman distance triathlon is something that's individual, depending on like everyone trains differently. Everyone has a different training load, volume base, and then for competition, everyone handles that volume differently. So I think I talked to Dr. Hiller, and he told me a lot about what his work and what he's done to prevent stuff specifically and complaints and stuff like that, specifically hyponatremia. So I really think it's very individualized, but I think and Casey could probably dive more into this too with hyponatremia because he looked specifically into that. But I think just balancing food intake and water intake and making sure you're overloading, not overloading with fluids, but also hydrating sufficiently is really important. So I guess just, yeah, it's very individual and like, sorry, I couldn't give a super specific answer, but definitely per
That's good.
person.
That's good. Casey, would you like to follow up with anything specific?
Yeah, I can specifically touch on EAH. So there was kind of a big shift in recommendations on fluid consumption in like the 80s, because before that, what they were really concerned about was dehydration and kind of the consequences of complications of that. But really in kind of the 80s, they realized the importance of sodium balance. And so they've kind of been trying to specify recommendations specifically with size, sex, and other factors. And that could be part of the reason that we're seeing a decrease in EAH. And some of some literature says that it may be decreasing over time as well. So
Great. Excellent. Are there any last questions? We've got a little bit of time left. We can take a question or two. I feel like I'm in class waiting. Okay, I'm going to take that as a no. I'd like to thank our sponsors for sponsoring our whole program. Please give our speakers, they did a wonderful job. Please give them a virtual round of applause. And we will see you our next meeting. Where is James? James.